Okay, so my name's Amy Chadwick and I'm the ward manager of the Acute Medical Unit at Mid Cheshire Hospital.
And my name's Jane Davis and I'm the Patient and Public Involvement Manager at Mid Cheshire. So just to kind of set the scene and give you a bit of background about Mid Cheshire NHS Foundation Trust, we comprise of three small hospitals, Leighton Hospital and Crewe, the Victoria Infirmary in Northwich and Elmhurst Intermediate Care Facility. So we've got 4,500 staff members and 540 inpatient beds, so relatively kind of small foundation trust. So a bit of background about the project. The precursor to this project was the National Inpatient Survey results. So we identified basically issues with discharge delays from what the patients were telling us from this survey. And through other patient and public involvement surveys that we do on a routine basis at the Trust. The National Inpatient Survey in 2015 had highlighted patient concerns around lengthy delays when it came to issuing and prescribing discharge medications following inpatient stays. So just one of the patient comments from the 2016 surveys was discharge procedure could be improved. So as we always do with national inpatient surveys, we take a trust-wide approach to action planning. We get a group together from across the trust, representations from all diverse areas, OTs, nurses, doctors, and look at what we can actually do. So what can we do at a trust level to improve discharge delays? So one of the main outcomes of the trust-wide project was the Your Guide to Discharge leaflet. Do you want to go back? I'm sorry. Which kind of communicated to patients what needs to be done prior to being discharged. Because when a patient hears that they can be discharged, they just think they can walk out the door. They don't understand that there are numerous things that need to happen before you actually can walk out the door. So it's improving patient information, and that's what the kind of trust-wide approach that we took. So on AMU, Amy kind of led this project, and she thought, what can we actually do on like a local level? What can we do that's going to make a tangible benefit actually on ward level, and how can we engage staff in this? So basically a project group was established. Again, it was important for the project team to be agile and with the ability to make rapid decisions. So we tested change on a small scale, introduced change and improvements quickly, and kind of built a really good momentum around seeing improvements. So the group met weekly, so changes could be made quickly and to ensure total success of the project. Okay, so they started off to kind of dissect discharge delays, so what were causing it, and identified waiting times for tablets to take home and also a general kind of lack of communication around discharge. Okay, over to you, Amy.
So we identified a number of actions. So the first protocol was to audit the number of medications that could actually be dispensed from our AMU stock. Unlike a lot of the other wards, we have a huge medication stock, so that was the first point. We audited the length of the time that our TCOs were taken to be dispensed by pharmacy. So our process is that they get written up by the doctors, they go down to pharmacy, they get booked in, which sometimes there can be a huge delay on when they get booked in, and it goes onto a tracker. And then look at the time that it took for them to be dispensed, and then we looked at ordering a machine. So that's just like the process that I've obviously just described. So our aim of the initiative was to bypass the dispense routine completely and dispense the medications on a local level. So we looked at the data in relation to the TTO dispensing. And we looked at the time difference between booking into pharmacy and out of pharmacy, and the time difference between the authorisation and booking in. So the figure showed that pre-label printer data that 52% of the medications could have been dispensed on AMU, and we also looked at the times that it took for pharmacy to dispense them. So the maximum time was like 204 minutes for pharmacy. And these were our order results following the implementation of the printer, so it went down to a minimum time of like 2 minutes for something to be dispensed on the ward. So patients that were waiting a huge length of time on the ward sat in a hospital bed. We also improved patient flow throughout the hospital as well, so beds were getting freed up quicker. So phase 3, these were some of the hurdles that we faced on a regular basis. The items of the TTOs weren't stocked on the ward, so then there was a review from pharmacy, so we looked at increasing our stock base on the ward. Sometimes there wasn't enough stock on the ward, so again we looked at increasing our stock. And there was no technician or pharmacist on the ward due to pharmacy commitments, and sometimes the dispensing computer was unavailable because it had been used by another member of staff. So it's been a huge success. So in terms of sharing the results, we've presented various presentations to forums within the trust highlighting the benefits at ward level and to the patients. We also looked at the data of complaints that we'd had in relation to dispensing of medications, and you can see we've only got one to date so far where somebody complained about waiting for their medications. And I think it's one of the surgical wards and the children's ward are also in the process
looking
of
to
implementing
the similar model.
So key learning points, the importance of good communication within the project team and the commitment to weekly meetings in the initial stages of the process. And as Jane said before, we had a focus group. It even included my housekeeper. You know, she was really pivotal, chasing computer services to make sure we got the printer installed. The presence of at least two pharmacists on the ward, and using the PDSA cycles, and just continually measuring for improvements. So project benefits, reduction in waiting times for TTOs. The main pharmacy has received less requests for TTOs, reduction in patient stay, and reducing our number of complaints around the TTO process. Any questions?
Wow.